Hi everyone, welcome to Gallbladder POCUS. My name is Kerry Spearing and I'm a PGY1 emergency medicine resident at the UBC Interior site. Today I will be talking about the utilization of ultrasound for gallbladder pathology. The objectives of my presentation are to review the indications for gallbladder eddy, to cover a stepwise approach to obtaining a view of the gallbladder, and image interpretation with a focus on the two binary questions of gallbladder eddy. Ultrasound is the most useful test to confirm or rule out gallbladder disease. Gallbladder eddy aims to answer two binary questions. Number 1, are there gallstones? And number 2, is there sonographic evidence of cholecystitis? Let's begin with a stepwise approach to obtaining a view. Choose the low-frequency curved array or phased array probe. Initial depth should be close to maximum to allow ample visualization of internal anatomy. Ensure you have selected the abdominal preset and, as always, be prepared to adjust your gain to improve your image. With your patient in supine, place the probe in the epigastrium in the longitudinal plane with the probe marker pointed towards your patient's head. Heel the probe cephalad to place the liver, which acts as your acoustic window, in the near field with the caudal tip of the liver on screen right. Slide the probe along the right costal margin from the epigastrium to the anterior axillary line. Keep the liver in view by adjusting your depth and degree to which you're heeling the probe cephalad. The gallbladder is usually located close to the midclavicular line at the costal margin. However, it can appear anywhere between the epigastrium and the anterior axillary line. Look for a cystic structure. If the gallbladder is not adequately visualized on your first sweep, try any of the following maneuvers. Number 1, repeat the slide after the patient has taken a deep breath and held it at maximum inspiration. This maneuver will move the liver caudally and may push the gallbladder out from behind the ribs and into view. Number 2, placing your patient in the left lateral decubitus position may also assist your scan by bringing the gallbladder out from under the ribs. Number 3, for high-lying gallbladders, you may attempt an intercostal approach. Place the probe in an intercostal space with the probe in the transverse plane. Start at the midclavicular line and move the probe methodically, first cephalad and cauded, and then medially and laterally while staying in an intercostal space. This approach may be easier with the smaller footprint of the phased array probe. And finally, for more lateral gallbladders, consider a lateral approach. Start by placing your probe on the right mid-axillary line in the longitudinal plane. Identify Morrison's pouch and then slowly slide the beam anteriorly until the gallbladder comes into view. Once you have identified a near-field cystic structure, confirm that it is in fact the gallbladder by observing its pear shape and long axis. Note that no other structure that may mimic the gallbladder will appear pear-shaped in long axis. Since the gallbladder has a variable lie, you must rotate your probe slowly to identify the true long and short axis. If you are unsure, here are some tips to assist you. Number 1, look for the exclamation point sign. The gallbladder in long axis will point towards the portal triad. Number 2, use color Doppler and look for an absence of flow to help differentiate the gallbladder from a vessel such as the IVC or portal vein. Number 3, ensure there is no peristalsis. Loops of bowel may look like cystic structures, but they will usually exhibit peristalsis when observed over time. Once you have identified the gallbladder in long axis, sweep through it slowly until it vanishes from view in each direction, looking for the presence of stones. Stones are most commonly located along the far field wall and in the neck, so pay particular attention to these areas. If no stones are present in the longitudinal axis, your scan is not determinate until you rotate your probe 90 degrees and scan the gallbladder in short axis as well. Now that we have covered how to successfully visualize the gallbladder, let's review image interpretation with a focus on the two binary questions of gallbladder eddy. Number 1, are there gallstones, yes or no? Stones demonstrate echogenicity and shadowing. They will appear as bright white structures within the gallbladder lumen, which cast a far-field shadow. All stones greater than 4 millimeters in diameter should cast a shadow. Stone shadows tend to have sharp, well-defined margins. If you are unsure about whether you are visualizing a stone, remember that stones are usually mobile and dependent. Have the patient roll onto their side or sit upright and watch for the stone to shift to the most dependent position. Two exceptions to this rule are cholesterol stones and stones stuck in the gallbladder neck. Moving on to the second binary question, are there signs suggestive of acute cholecystitis? The 4 signs include a positive sonographic Murphy's sign, gallbladder wall thickening, pericholecystic fluid, and gallbladder distension. A positive sonographic Murphy's sign is elicited when the patient experiences maximal pain while probe pressure is applied directly over the gallbladder fundus. Note that the absence of stones and a negative sonographic Murphy's has a high negative predictive value for cholecystitis. Gallbladder wall thickening is measured at the narrowest point of the anterior gallbladder wall in short axis. Normal wall thickness is accepted to be 3 millimeters or less. Note that gallbladder wall thickening is more sensitive than specific, as there are many pathologies that can lead to wall thickening. Pericholecystic fluid is a more specific finding for acute cholecystitis when it is present in the setting of a patient with a high clinical suspicion. And finally, gallbladder distension may be present when the gallbladder is more than 10 centimeters in length and more than 5 centimeters in diameter. This is a non-specific finding, but can be caused by an obstructing stone. That brings us to the end of this video showcasing a basic approach to gallbladder eddy. I have covered the indications for the scan, a stepwise approach to obtaining an image, and image interpretation with a focus on the 2 binary questions of gallbladder eddy. I'd like to extend a big thank you to Dr. Jeff Sands, our ultrasound guru who heads the POCUS rotation at the UBC Emergency Medicine Interior Site, to the KGH emergency medicine staff who volunteered their time to teach during the rotation, and to my fellow residents, Britt Bailey and Mark Sanderson, who volunteered their time to the making of this video.